إخواننا وزملائنا أهلا بكم في محاضرة جديدة, and this time around it's going to be about hyperparathyroidism. This lecture will precede a few more lectures about different case scenarios and causes of hypercalcemia, with review of literature and abundance of case vignettes as well. Now, in terms of classification, the commonest cause of hyperpara is the primary source, primary adenoma or multiple adenomas. Secondary cause, usually related to impaired kidney function, this could be as moderate as an eGFR between 30 and 60. Usually in these cases, the patient will have normal calcium level but slightly raised PTH to compensate for the renal impairment or for the glomerular loss. And tertiary cause, and this is what we see when someone who had prolonged history of secondary hyperparathyroidism, which eventually culminate into autonomous adenomas and subsequent autonomous hyperparathyroidism. We also see that in X-linked hypophosphatemic rickets and oncogenic osteomalacia and long-standing idiopathic hypercalciuria. So to start with, parathyroid hormone is a very short-lived hormone. It only lasts in the blood for about a few minutes, I think anything between 3 to 5 minutes, and it serves to regulate calcium homeostasis alongside vitamin D and calcitonin. And the symptoms we get from hypercalcemia, whether it's related to hyperpara or any other cause, is usually what's the traditional proverb, a medical proverb, which was passed on from one generation to the other. As you could see it on your slide there: bones, stones, abdominal groans, and psychic moans. So there is, generally speaking, a constitutional symptoms related to hypercalcemia, and it depends on the degree of hypercalcemia. You have to be really mindful of these important details. So a mild hypercalcemia might not give you any constitutional symptoms. I've seen patients who have weight loss. Easy fatigability is a very common symptoms, by the way, and polyuria and nocturia is also common, particularly as the calcium level climbs up, and myalgia, proximal myopathy, refractory peptic ulcer. Unfortunately, many physicians forget to check the serum calcium when they seeing a patient with GI ulcers. And finally, depression and of variable degrees, and even psychosis. Now, the important aspect when we diagnose someone with hyperparathyroidism and hypercalcemia is the next step after establishing the biochemical diagnosis will be to elicit if there is any end organ damage. So hyperpara can cause osteoporosis, can cause nephrolithiasis, pancreatitis in severe cases, and, as I said, refractory peptic ulcer. Now, how to diagnose it? Usually you have either high PTH or inappropriately normal parathyroid hormone in the face of hypercalcemia. The phosphate will be on the low side, because the parathyroid hormone, one of its main functions is in order to maintain a calcium homeostasis is to wash out the phosphate through the kidneys. The vitamin, the 125 dihydroxy D3 tend to be either high or even high normal. It doesn't always have to be high. And the 25 hydroxy D2 tend to be either low or normal. Now, the spectrum of biochemical profile is related to the degree of hypercalcemia, which is dictated by the degree of hyperpara. So if you have a large single parathyroid adenoma, you would have almost certainly you'd have a significant hypercalcemia. Or if you have double adenomas and so forth and so on. The next step after we establish the biochemical diagnosis, and I have to stress here, no biochemical diagnosis will be finalized until you have the 24-hour urine calcium collection with calcium levels more than 7 millimole per day. And that's significant, definitely, and the reason we do that is to rule out the other potential causes of familial hypercalciuric or hypocalciuric hypercalcemia. Now, once we establish the diagnosis, the next step will be localization. The most readily available images modality is ultrasound. Now we have to remember that parathyroid gland is way too small to be picked up by way too small to be picked up by ultrasound. So whenever there is whenever the ultrasound shows a parathyroid or can delineate a parathyroid gland, then only then when you know that this is definitely an enlarged gland, because normal gland would not show on the ultrasound. The problem and the downsides of the ultrasound with respect to picking up the parathyroid adenoma is the fact that if there is a multinodular goiter, it won't pick it up. If the gland is in the thyroid bed itself, and that will be very difficult to elicit on ultrasound. We also do intraoperative ultrasound, which is a lot more sensitive. Now, with regards to parathyroid system, maybe this is more accurate than the ultrasound. It works through a delayed washout mechanism. So both the parathyroid and the thyroid glands will take up the isotope, but the parathyroid gland, particularly the overactive one, will tend to retain it for a much longer time. The advantage of this modality is its ease of use, and obviously it's not invasive. It has a low radiation exposure, about 12 MCV, and also it could localize ectopic parathyroid glands. However, it doesn't perform all that well when you have double adenoma or when you have intrathyroidal adenoma as well. The third modality is 4D CT of the neck. This although has a lot of high radiation dose exposure, but nevertheless it's actually more accurate than the system EB and the ultrasound, and we do use it as a third line if the previous two did not isolate the culprit parathyroid gland, and we use it in conjunction, and will improve the sensitivity almost just over 90%. And it can pick up double adenomas, small parathyroid adenomas, and intrathyroid adenomas as well. Now, with respect to whom to refer to the surgeon, any symptomatic patients with hyperpara need to be offered surgical option. However, there are lots of patients who are asymptomatic, those who have mild hypercalcemia. We tend not to refer them if they were very old, we tend not to refer them to the surgeon if they did not develop any end organ damage in terms of osteoporosis or renal impairment or gastric ulcers. The reason why the guidelines suggested a cutoff of 50 below which we should offer treatment for even asymptomatic hypercalcemia, that was driven by the patient's health economic perspective. So once they have hypercalcemia or hyperpara deemed for medical management, then you are obliged to follow them longitudinally for the rest of their lives, and that can be very costly if you start surveilling and the hypercalcium below the age of 50, and hence the panel was suggesting that we offer treatment below this age group, even though they have only mild hypercalcemia or asymptomatic altogether. Finally, we'll move on to secondary hyperparathyroidism. Now, the mechanism that drives the parathyroid to be overactive in CKD is multifactorial. So, damaged nephrons will be less active in terms of or less effective in terms of activating 25-hydroxy-D2 into 1,25-dihydroxy-D3, so they usually have lower calcitriol level. So that's one. And as we all know, that we do offer calcitriol to patients with CKD. Other mechanism is uremia and hyperphosphatemia. So those all together will lead to for the parathyroid gland to oversecrete PTH in order to compensate and maintain the phosphate at a normal level and the calcium as well. Once this mechanism fails after considerable time, then you will have tertiary hyperpara, as we mentioned before, and that's when you have the usual hypercalcemic high PTH profile, and the latter obviously requires surgery. But the surgical option for tertiary hyper is different, when you have to take most of the parathyroid glands and reimplanting half of the parathyroid gland in the forearm and monitor it longitudinally with ultrasounds. I'll stop at this point, and in the next few lectures we start looking into other causes of hypercalcemia and case vignettes that I hope you'll find beneficial. Thank you indeed.